Hello, everyone, and welcome to PACE Financial Forensics. It is my pleasure to welcome you on behalf of all the partners that are working together on this effort. I'm Jessica. I am the head of marketing at IntusCare, and I am pleased to be joined by a number of other experts. I want to introduce each one of them. First, with HMA is Don Novo. He is a managing principal at Health Management Associates. He has more than 12 years of experience spearheading Medicaid and Medicare initiatives with a focus on developing new PACE and Medicare Advantage plans. He's a former Medicaid administrator and a CMS federal regulator. He brings over 30 years of expertise in PACE program design, operations, and regulatory oversight. Welcome, Don. We also have David Walters, who's a senior consulting actuary from Wakely Consulting Group, which is an HMA company. He has extensive experience in PACE, Medicare Part D, and pharmacy analytics. Welcome, David. We have Melissa Bolish from IntusCare. She is the Director of Risk Adjustment and a key architect in IRIS, which is our Intus Revenue Integrity System. She's a registered nurse, a certified risk adjustment coder, and she brings over a decade of experience to her work supporting PACE programs. Then we have Greg Swarhawk from VisibilEDI. He's the Chief Operating Officer there. He's a leading healthcare technology service provider. VisibilEDI delivers EDI gateway and encounter data management services for CMS, Medicare, and state Medicaid programs. And VisibilEDI supports over 80% of PACE plans through automated, intelligent, and transparent EDI workflow processes. Welcome, Greg. And finally, we have Brad Gobert from MedVision QuickCap. He's an implementation and training manager there. He leads clients' onboarding, system configuration, and user training. He is known for his hands-on approach, clear communication, and commitment to ensuring PACE clients feel supported throughout every stage of implementation. So welcome to our esteemed experts. Before we dive into the content today, I just wanted to orient you all a little bit to this webinar Teams version. We have a chat available. Feel free to chat throughout our webinar today. We'd love to hear from you. If you want to try it out right now, please go ahead and put your name and which PACE organization you represent into the chat. We'd love to say hello. We also have questions and answers available throughout the session as well, which is a separate button. So anytime that you have a question, feel free to go into the Q&A icon that's at the top of your screen, add in your question. We will save time at the end of the session to answer as many questions as we can. I do want to note, even if you don't have a question, I encourage you to go in and see what others are asking. You can actually upvote for the questions that you'd love to hear the answers on. And we will answer the questions in order of interest at the end of the session today. So with that backdrop, a little bit of logistics, I am pleased to share our agenda for today. We will start with HMA Wakely. We'll talk a lot about investigating the revenue gap that is coming upon us with EDS and v28 on the horizon. IntusCare and MedVision will talk a little bit about securing the right evidence to avoid said gap. And then VisibilEDI will talk about validating and presenting the case to CMS to hopefully close the gap completely. And then finally, we'll close out with HMA Wakely to talk about how to close the case and make sure that you have indeed closed that gap. So without further ado, I am going to pass it over to Don, who will talk about investigating the revenue gap. Take it away, Don.
Great. Thanks, Jessica. Good morning, everyone, or afternoon, depending upon where you're from. We're going to talk a little bit about investigating the revenue gap. And to do that today, to start off, we really want to talk about and orient everybody just to the PACE revenue that organizations typically receive from their various Medicare, Medicaid, state agencies, and in some instances, private pay. So if we can move to the next slide. As you can see on the graphic, we talk a little bit about the different payer sources. So for today's discussion, we're primarily focusing on Medicare revenue, but PACE programs also, as everyone knows, receive significant funding from their state Medicaid agency for all of the Medicaid services. And then in some situations, there's also private pay where participants are paying towards the cost of their care. For our discussions, as I mentioned, we're going to talk about the Medicare A and B, Parts A and B, which typically is rolled into a Medicare Part C capitation, which is the way that CMS reimburses capitated programs. And then we're going to talk a little bit about the Medicare Part D reimbursement for pharmacy services. One of the things that we want to talk about and that we're going to review in the next couple of slides is kind of benchmark rates and how those benchmark rates update annually from year to year. CMS CMS does release a final notice, and that final notice provides all of the details on the Medicare revenue streams, so the capitation rates for A and B services through the Part C payment, and also the Part D revenue streams. Jessica, I think we can move to the next slide. And so what we really want to emphasize today is how the changes that have occurred over the past 5 years looking at risk revenue. And in this instance, in this slide, we're looking at the at-risk Part C revenue, which is the payment for all of the Medicare A and B services. And you can see that over the past 5 years, the trend has gone upwards where organizations are increasingly at higher risk for the revenue that they're receiving from CMS related to Part C. If we can move to the next slide, we're going to look a little, and this slide really kind of shows you the benchmarks just over the 5-year trajectory. So you can see how the rates have increased over the previous 5 years. You can see the risk scores have remained the same. You can see the actual payments and then the growth rate. Growing and increasingly, it's important because, as we mentioned, these organizations are increasingly more at risk for the revenue that they're receiving. Medicare Part C represents about 40% of non-Part D revenue in 2024. So you can see the factor of how this at-risk situation is increasing. So I think we can move to the next slide. Now we want to also kind of look at the Part D revenue increases dramatically. And you can see between 2016 to 2025, when we're looking at the 10-year view of the subsidy, that we've had significant, that there have been decreases upwards through 2023, and then some significant increases through 24 and 25. I think we can move to the next slide. And with that, my colleague David is going to talk a little bit about investigating the revenue gap and how that comes into play. David?
Thanks, Don. Great introduction. And before, Jessica, do you mind moving back just to the Part D slide for a brief minute? I just wanted to highlight, so we've seen a pretty steady decline in Part D at-risk revenues from 2016 to 2023, a fairly dramatic increase over the past few years. I just want to highlight for 2026, that bar would, as some people would say, literally be off the chart. It continues to increase. It's about $200, and there is an entirely new other risk adjustment model for Part D. I've got 2 day jobs. I'm a PACE actuary and a Part D actuary. That sounds like a lot to most people, but I've learned in the PACE community that's probably nothing to the people that do 5 or 6 jobs on a daily basis. But so I know about the Part D, and if you're not paying attention from both a risk adjustment perspective and from a Medicare Part D bid perspective, you're definitely losing out on the revenue you should be getting. So this is just want to highlight that. Definitely pay attention to it. And as an aside, Wakely does do Part D PACE bids if anybody's interested. So we'll move on. We can move on. Thank you. So moving on to this change in risk adjustment operations and concept that I think everybody on this call is probably aware of by this point. There's a pretty severe change that is coming to the PACE world from a risk adjustment perspective. So we're titling this slide, Medicare Solutions PACE Problems. What do we mean by this? So CMS has been introducing in the Medicare Advantage world a series of changes to the risk adjustment model over the past decade. This RAPS-to-EDS transition, I think, was first onboarded around 2015. It was originally built on the same model. It went RAPS v28 to EDS v28, and it was just a difference in how diagnoses are submitted. Amongst other things, we'll talk about this more a little bit later, but the EDS process of diagnosis submission is infinitely more complicated than the RAPS process. So not only are you dealing with this process of converting RAPS to EDS, but you're also roping in two significant model changes that have clinical and operational impacts that also need to be addressed. The v28 to v24 change that occurred in 2020 introduced the concept of HCC coefficient counts, which gives you additional risk score just based on the number of conditions you have. And then the v24 to v28 changeover that's been onboarded between 23 and 26 kind of takes a scalpel approach and tries to de-emphasize or eliminate some of the discretionary coding practices that have been highly utilized by a number of very large players in the Medicare Advantage space. So there are a significant amount of changes from a conceptual, clinical, and operational standpoint that are all being wrapped into one in this model change. And these are really problems focused on a Medicare population that are now migrating to PACE. So there's a lot to pay attention to. Okay, move on. All right, so CMS released in the advance notice back in February of this year a proposed timeline on how this transition will occur. Proposed a 90-10 split for 2026 that you'll see in about 3 weeks when that first check is issued, and supporting MMR and PPR documents come along with that. And in that advance notice, CMS proposed a 4-year transition period from 26 to 29, where by 2029, risk scores will be determined by the EDS model on 100% basis. No, before that, it's a progressive blend where it gets to 50-50 by 2028. And then finally in 2029, as I said, is full 100% EDS. This calendar is subject to change. This was, in my opinion, prominently not republished in the final rate notice. And when Medicare originally made this EDS to RAPS transition, or RAPS EDS transition, it was delayed for 2 years just because that EDS to RAP or EDS transition in of itself is a very complex process. So it's possible this will be delayed or, for a little bit or extended, but I wouldn't bank on it, right? Now that these capabilities have been kind of established in the MA space, CMS just may say, okay, we're going to go through this as planned, right? So what does this timeline look like on a plan year basis? Next slide. See this chart, noticing that 2026 initial line, which will be representative of the money you actually get in January, that diagnosis measurement period and submission deadline has already passed about 3 months ago. So it is important that PACE organizations develop competencies pretty quickly here, right? The measurement period that will determine the final revenue for 2026 is about to expire here in 3 weeks. So the clinical education that needs to go out to your provider community should be happening right now. The prospective nature of the CMS HCC risk adjustment model kind of accelerates the timeline for when these competencies need to be established. So it's important, not only from an operational standpoint that you pair with the right experts that can do this, but you also provide and migrate that clinical education down to every member of your provider community that contributes to your coding efforts. Okay. Next slide. This slide is a little bit busy, so I'm just going to describe it at a high level. It's not intended to be, used for quantitative development of, oh my goodness, this is how much your risk score is going to change. It's obviously meant to be visual. The bar graphs show the average condition coefficients for the respective diagnostic condition groups. As you can, the RAPS is denoted by the darker blue. The proposed EDS v28 is the proposed, it's going to happen, is the lighter blue. And you can see for a lot of these diagnostic groups, the condition coefficient weight is pretty far down. That's what that represents. So there are a lot of de-emphasizing of certain targeted groups of conditions that need to be paid attention to. And then also the prevalence that denotes the count of ICD-10 diagnosis codes that are going to map to a payment condition. So a couple things. One thing that the V28 model did is, aside from de-emphasizing a lot of these discretionary or judgment-based condition codes and coefficients, it also greatly reduced the number of ICD-10 codes that will actually map to payment condition. In general, there's a few diagnostic conditions groups that have a little more, but in general, that dark line is above that lighter yellow line. So that's something to pay attention to, and that's the kind of the clinician side of the education needs to happen. Moving on. So this slide, we have represented the EDS process via a Rube Goldberg machine cartoon, which I'm told was all the rage 60, 70 years ago in the newspaper. It is an extremely complex process compared to RAPS. For RAPS, so a couple differences. First, RAPS is less operationally burdensome. That's the understatement of the webinar. For RAPS, first, the filtering in terms of what is acceptable from a claim risk adjustable standpoint, that filtering is done at the plan. The filtering to decide what claim qualifies as risk adjustable in the EDS world is performed by CMS, and that's done for most non-inpatient claims by reviewing and looking up a certain set of CPT and HCPCS codes, which are deemed eligible for risk adjustment. But CMS makes that determination. From an operational submission standpoint, EDS claims are submitted via these 837 claim files, which are, as I said before, exponentially more complicated in file structure than a RAPS diagnosis claim, which is 4, 5, 6 fields, flat file, but pretty easy to populate. These 837 nested loop claim structures is incredibly complicated to navigate unless you have a real expert handling that claim creation process. So that's the operational difference. And then the process for the EDS risk adjustment, once the plan submits the 837 file, CMS will provide intermediary response files in the form of MAO2 files and 277 files that determine at a claim line and claim level if that 837 claim file has all of the required information in that claim to even be acceptable. So from just a claim file structure standpoint, if that 837 file is missing elements that are deemed necessary for a claim by CMS, they're going to toss it out regardless of whether that claim should or should not be risk adjustable from a clinical standpoint. Then once you get all the way through that process of making sure the 837 file is clean and qualified for risk adjustment, CMS passes back an MAO4 member and diagnosis file that shows all of your accepted diagnoses, which then you can run and say, okay, we're good on these diagnoses. These will count towards risk adjustment, and you can calculate your risk score based on those response files. But it is, it's hard to overstate how much more difficult an EDS submission process is than the RAPS process of old, which is why you need a plethora of expert vendors to really help you get all the way there. Okay, next. So this is taken from an MPA study that shows the gap between the two methods, and this was assessed, I think, and published in March at the Spring Policy Forum in Washington, D.C. And as of the time when the MPA did their study, they were noting a 30% drop in risk scores between the RAPS and EDS union, and then the EDS by itself, with the model difference contributing as well. That's 3% coming up next year, right? 3% drop in revenue is pretty significant because it all hits the bottom line, right? 3% sounds like just a little bit until you think about that and related to your margin. I mean, that's a lot of the margin that PACE plans are working with. So it's pretty critical right now, and will get even more critical. And just as an aside, that's the average. When Wakely has done these studies on an individual PACE organization basis, we're seeing anywhere from 10 to 50% gap. So if you're on the 50% side, that's something that needs to be addressed immediately. Next slide. And then, so we've talked about how complicated this EDS process is. How do you crack the case? Kind of the old adage of raising a child, it takes a village. It takes a lot of expert partners to pull this, to be able to do this adequately. IntusCare is going to help you, secure the evidence and make sure that you're not starting out at a deficit position from which it's then unrecoverable, right? You need to have quality encounter information going into this process, or you're going to operate and start from deficit, which you cannot recover from. MedVision comes in and provides, support to make sure that from a clinical perspective, they take all the data, claim data, to make sure that your clinicians are accurately capturing all of the revenue you deserve to get to take care of your members, right? That's very important. And VisibilEDI, everybody talk about this more, they handle the very complex process of getting these files prepared, submitted, and reconciling. And then once you get all of those partners to help you out and make sure that you are getting the revenue you deserve, Wakely comes in and can assess the progress on a quarterly or semi-annual basis. And we did this for MA plans from the small players up through the very, very largest organization you can think of 5-10 years ago. And took a couple of years to adequately close that gap. And so that's where we come in at the beginning and the end to first assess where the gap is and then measure progress along the way. And I think with that, I'll pass it off.
All right. Hello, everyone. Melissa from IntusCare, and we are going to talk about making sure internally that we are accounting for every potential diagnosis that is out there and getting that captured. So we can jump into the first slide. So what is our dilemma here? Providers are not taught to be coders. Providers are taught to provide care. They don't know diagnosis coding. They don't want to spend their time learning diagnosis coding. They want to provide care. And everything that my colleagues have talked about before me here, none of that is even going to come into play if our providers aren't getting things documented. At the end of the day, it comes down to that provider understanding what needs to be documented, how it needs to be documented so that it can get coded and go through all of these processes. So our goal here at IntusCare is to assist that provider with that very tedious process of making sure that everything is available to them, that they can continue to provide care, but have the tools in front of them that they need to get everything documented appropriately. So we can go to the next slide. Our solution is IRIS, which is our Intus Revenue Integrity System. And we pair that with CareHub, and it's a 1-2 punch that really allows the provider to see what is important in terms of documentation. We start that pre-visit planning for all of our programs, and how we start that pre-visit planning is by looking at the entire medical record and getting a list of all of our recapture conditions, all of our potential conditions, so things that might exist that just have not yet been diagnosed or documented for that member. We get that all together in the form of a pre-encounter prep. This includes our HCCs, so our payment for Part C, and then we're also including the RX HCCs in there for Part D as well. David talked a little bit about this. For a long time, the RX HCCs have just kind of been ignored. We cannot ignore RX HCCs with the increasing value that are coming from those. So those RX HCCs are equally as important as the HCCs to get them documented and truly realize the correct revenue. Partnering the pre-encounter prep with CareHub makes it much more seamless for that provider because the pre-encounter prep is visualized right within the patient chart. So as they're in that patient chart, they're getting ready to do an assessment. They open up their pre-encounter prep and their list is there for them. They can see exactly what has already been captured for the year. They can see what is still an outstanding opportunity, and it gives them time to do some research to determine if one of the predictive conditions that we brought forward is applicable before that assessment. So when they see that member for their annual assessment, they know these are some of the things that are outstanding that I need to assess for, and then make sure I'm getting it documented. So we'll go ahead to the next slide. And this is just an overview of what that looks like. We start with the pre-encounter prep, and then your providers will go in, they will do their assessment, utilizing that pre-encounter prep, making sure they're not missing any of those HCCs and those RX HCCs. Once that assessment has been signed and closed, what is of utmost importance is making sure that the diagnosis is supported. If we do not see support that is showing that that condition has affected the care, management, and treatment of that patient, it's not going to pass an audit from the OIG if we're ever audited in PACE. As we're making these moves, aligning ourselves with Medicare Advantage, we're opening the door to get audits. And we need to be ready, and we need to get ready now and make sure that everything is documented and supported. And how we do that is our risk adjustment coders. They're all certified onshore risk adjustment coders are going to look at that documentation. And if there is not support for a diagnosis, we're going to send a query to that provider and ask them to go in and amend their note and add that additional information. We want to do that because we want to know that on those assessments, our diagnoses have been completely supported. We can lay our heads down at night and go to sleep and not be worried and concerned that, oh my gosh, I might get an audit and I might have to give money back. Just making sure that every single thing that's documented is supported, coded appropriately, and then all of the things that we talked about before this can then happen, and you know that it's going to be correct. So we will go to the next slide. And again, as some of my colleagues have talked about, education right now, it needs to be happening. Our providers need to know that there are changes that are occurring. They need to know why they're being asked to do this additional information. And how we handle that here at IntusCare is we have consultants, our risk adjustment consultants that are in there working with our plans day in and day out. And as they see, oh, you know what, I'm routinely having to send Dr. Jones a query and ask Dr. Jones to beef up their documentation so it's completely supported. They can have a focused one-on-one session with Dr. Jones, talk to them, talk to him or her, educate him or her, make sure that they understand why it is so important. So one of the unique things is with IntusCare is just that one-on-one education that we're doing with our providers and making sure that they truly understand why we're asking the things that we're asking. And then they're ready to go into the transition because they know the who and why. And that is making sure that we have all of the internal evidence. So everything that is happening in the center is going to build that risk score. We also know that there's external evidence, all of those things that are happening outside of your program. And with that, I will give it to Brad to talk about that external evidence.
Yes, thank you. And I'm Brad from MedVision, and be focusing on our quick cap solution as part of this whole process, and how that solution allows our PACE programs to secure our external evidence. So we're looking for, the ability to process all of those external claims. How do we address that revenue gap? There's several ways, but one of them is we need to make sure that we're delivering clean, complete data, stronger HCC documentation, automated coding quality checks, making sure that there's an integration in our clinical and claims workflow, so that ultimately we're improving our accuracy and ensuring that there are no risk-driving conditions that are missed. So we can go on to the next slide here. So there's three main areas that I'm going to be talking about today, and how QuickCap helps in these three areas. So we have collecting, validating, and then processing. So in all of these areas, while we're focusing on bridging that revenue gap, there's also discussions and things that can be done on the expense side as well, automation side, that can also help bridge that gap as well, not necessarily focusing just on that revenue side. So on the collection side, there's a couple of things that we need to make sure we do. One is we need to make sure we're collecting, clean data that's coming into the system. We want to make sure that that data, as much as possible, is coming in electronically. I know with a lot of the PACE programs that I've worked with and that QuickCap has worked with over time, they may get a good amount of claims that are still coming in on paper claim forms. So, from making sure we have valid data and clean data, there's always that opportunity, if you're manually entering data into a system, that there could be errors. And it's also just the time that it takes for internal resources to manually enter that data into the system. So from that collecting data perspective, we want to try and make sure that we're collecting as much of that data as possible electronically, so that we're not using as many manual resources as we need to put that in manually. It may even be giving some of our providers the ability to just create a claim directly within a provider portal, instead of printing out and mailing in a paper claim form. So there's a number of things that we can do there on that collection side. We also want to make sure, QuickCap's main piece of this whole process is making sure that your claims are adjudicated and paid correctly and efficiently. So you want to make sure that you have all of your, that your fee schedules and your contracts are all set up appropriately, that there's easy to maintain going forward, once again, from a manual process, so that you don't have to do all those one by one. And you want to make sure that you have as many claims going through that process through like an auto adjudication or an auto routing type rule, so that you're not manually reviewing every single one of those claims. So that's part of that, actually then validating that data to make sure that everything that is coming in, that we're identifying, are there any errors? Are we flagging anything for review? And then as part of that also comes in from the revenue gap side, is identifying those HCCs that may be missed. So one big thing that we can do is take a look at, here are all those, for example, diagnosis codes that were reported on the authorization side, and are those same codes then being reported on the claims that are coming in that are matching up with those authorizations? And we want to make sure that that authorization mapping also is taking place automatically, that we don't have to manually go out and find a valid authorization if you do have providers that are submitting claims, for example, that require an authorization but do not have, don't have an authorization number on the actual claim itself that's coming in. So definitely, being able to automate that auth matching is important as well. One, to make that claims adjudication process as swift as possible, as well as also making sure that you are then able to match up that authorization data with the claims data and identify those missing diagnosis codes. We also want to make sure on a payment side that we're once again doing things electronically instead of manually. You know, if we're able to have as many of our providers as possible being paid via an electronic payment instead of printing out paper checks, printing out paper EOBs, you know, costs of printing plus mailing those, that can add up over time. So we definitely want to look at that as well and make sure that we have a system in place that allows us to do that from a claims adjudication. And then specifically on the, you know, the coding side and making sure that we're capturing those missing diagnosis codes, we want to make sure we have a system in place where we're not just going through one by one claims to see, okay, this particular claim could have had an additional diagnosis code on it based upon either previous claim data or previous authorization data that was not there. We also need to be able to see that at a higher level. Do we have certain providers or organizations or practices where that's happening on a more regular basis? Do we need to reach out and have some of that education to say, you know, once again, just like we were talking about on the front end, when we're doing that claims adjudication, our claims adjudicators are not, they're not experts on the coding as well. When they're looking at an individual claim, they're not necessarily identifying, is this claim, you know, missing a possible diagnosis code that could lead to additional revenue down the road. So we need to make sure we have that reporting in place and those resources in place that are going to review that information that can be generated out of the system to identify where we can improve, where we can make sure we can do that outreach so that we can basically bridge those gaps and make sure those additional diagnosis codes that are out there, that those are captured. And once again, as we talked about before, make sure there is that evidence to show that they are valid diagnosis codes, and we have that evidence to back it up. Once you've done that validation and processing of the claims themselves, you're able to report on that data, identify gaps, and bridge those gaps. The next piece is you want to make sure you're able to then, you know, send that information out to the appropriate entities with that encounter data. And so I'll pass it on to Greg, who can talk about after we've processed all those claims within QuickCap, then how all that claims data goes to VisibilEDI so they can actually generate those encounter files and then provide that data to the entities that need it.
Thank you, Brad. As Don and David mentioned, the data submission process is complex. The RAPS format, very simple. The X12-837 format provides a lot of data collection opportunities. This is CMS's intent for both medical, as we know, dental, supplemental, vision, et cetera. It's just going to continue to grow in the complexity. And the data capturing process, as Brad and Melissa said, the validation, having a clean data collection process is key to the quality of that entire ecosystem workflows. Next slide, please. Ultimately, the goal is to simplify the complexity and allay any fears of the unknown with facts and supporting evidence. The golden rule essentially is achieved by that partner cohesiveness, collaboration, contributing to PACE organization's success. Complete and accurate is very, very key in this case. And sorry, I got a little off track here with my slide. Apologies. The key is to have a good data collection process and essentially make sure that's complete early on in the process. Having the tools, the built-in mechanisms that ensure data inputs are being captured appropriately, and so on and so forth. Accuracy is built in from the rule set, and the rule set essentially is looking at the rules that both CMS and state Medicaid compliance guidelines are based upon. Monitoring the anomalies through the inspection to make sure what's expected is actually being submitted. And then, of course, timely is very important. And timely could also mean getting more data in earlier in the process. There are essentially 13 opportunities if you're on a weekly basis to submit data and get feedback and be able to adjust that accordingly. Next slide, please. So essentially, the collection process, as we've mentioned, first and foremost is a standardization across the partner ecosystem and making sure that everything is automated, intelligent, has built-in transparency. Most importantly, there are visual feedback loops. Those visual feedback loops essentially do help to identify each step in the process from collection to validation during that review process to the submission and the reconciliation back to the original processes. So essentially, data that is being submitted into the VisibilEDI Encounter Data Gateway is inspected and validated. So the CMS rules and in many cases state level rules are applied to basically prepare it for the best possible submission acceptance on the first pass. If the rules say it would not be accepted based on known rules and so on, then stop it, review it. Those ones that don't pass, you have an opportunity to correct it. Opportunity to look backwards into the validation. Was the validation correct? Was there a missing rule or a missing check against some piece of data that should be input into that validation process? Or was the data not accurate at the collection point? And over time, that symbiotic feedback loop essentially ensures that the least amount of data gets prepended during that review process and held up for review, and the most amount of data gets submitted. So in the case of the data that does get validated and submitting that using the standard formats, collecting the most data possible that CMS is looking to receive, and that accuracy of that, then the feedback from CMS is essentially saying, oh, there are new rules you may not know about. We should be ahead of that. Or there's something in enrollment, there's something in some other piece of an input or a pre-check that needs to be adjusted, needs to be added back in to the process to ensure that the acceptance rate at CMS first pass, so those MAO2s come back clean and the data gets put into the process for risk adjustment. The goal ultimately is that automation and transparency. And CMS, first and foremost, is looking for the most and complete, accurate data that tells the best story. And ultimately, PACE organizations are looking to tell the best story and ultimately get the best outcomes from a financial perspective and get the feedback that's necessary that allows them to adjust care, adjust systems, adjust processes, and so on and so forth. So essentially, that standardization across the partner ecosystem, that automation, the transparency, the visual feedback loops, and ultimately partners working together, VisibilEDI, Intus, MedVision, HMS, and so on, and any other partner that is basically conspiring for that best ecosystem, that best technology flow that ultimately provides the PACE organizations the ability to understand what they need to do, what their part is, and that their partner community is ultimately giving them the best tools and the best counsel to conspire for their success. Thank you.
All right, this is me. So Wakely then enters the process once again by assessing from a financial perspective how your progress is coming along. So we assess that RAPS-EDS gap on the front end for both the Medicare Part C revenue stream and the Medicare Part D revenue stream, which, as we've talked about several times, is now pretty important, and tell you how you're progressing, right? And as I think this webinar has pretty clearly demonstrated, it takes a village. It takes expertise in several distinct modalities to really be able to make sure you're getting the revenue you deserve, right? I think it's safe to say there is, on the Medicaid side, some concern that the revenue trend may be flat or decreasing over the next few years. It is possible with this transition that could happen in Medicare, but it is also possible if you build up your expertise with the help of the expert people in the space, along with the MA benchmark trend and the national average benchmark in Part D that keeps increasing. If you're coding and developing these competencies and getting your EDS risk score to where it needs to be, you can actually increase your revenue quite significantly on the Medicare side, right? So, well, this should be, in some ways, if you haven't been paying attention, a bit of a wake-up call. There is also opportunity here. And that's, again, where Wakely comes in. After all of these really smart people do these really hard things, we come in and say, okay, this is where you're at now versus 3 months ago, and can assess where you need to be to fully close that gap. I think with that, we can pass it back to Jessica for questions and answers.
Yeah, thank you so much, David, and thank you so much to all of our experts today in helping us close the case. We do have, as promised, a few minutes here for questions and answers. So if you have a question that you haven't yet put into the Q&A, please go ahead and do that. And also, if even, like I said before, even if you don't have a question, go in there and see if there's any questions that you are most interested in hearing the answers on, and we will start from there. While you're thinking about your questions, I did also want to ask you to put in the chat if there's any other topics that you'd love to hear kind of this group share about. I think today's session has been incredibly educational, and there may be other areas that we could prepare webinars in the future for you. So if you have ideas about that, please put those into the chat as we go through the Q&A. I know one that we came up amongst ourselves last time we met as a group was Medicaid, so that could be an area of interest. If so, put it into the chat, and if there's any other kind of hot topics that are on your mind, please put those into the chat as well. So without further ado, I will get us kicked off here with our first question. Looks like it is, can we discuss in more detail what we mean for HCC scores for Part D RXs? And that's from Ryan. Anybody want to take that first question?
Can you repeat the question just so I make answer precisely?
Sure. Can we discuss in more detail what we mean for HCC scores for Part D RXs? Okay.
So there's an entirely separate risk adjustment model that develops your Part D risk score. Entirely new set of condition coefficients and an entirely different set of ICD code mappings to those condition coefficients. Now, obviously, there's some overlap, right? HIV is a paid condition coefficient on the Part C side, and it is a very highly reimbursable paid condition on the Part D side. But there are a lot of differences. The similarity is it's the same set of diagnostic data that goes into it. So from a clinical standpoint, it's a little bit different of a focus in terms of making sure the set of conditions that have highest reimbursement scores in Part D are adequately coded. But from an operational standpoint, it's the same. So if you solve that RAPS-to-EDS gap for Part C side, that will translate to the Part D side. Open up to my other colleagues to discuss more intricacies.
Anybody have anything they'd like to add?
Just what I would add from a clinical perspective, when you think of an HCC, you're thinking of those big chronic conditions or those bigger acute conditions that it's going to land somebody in the hospital and the plan is going to have to pay for that. thinking clinically about RxHCCs, those are going to be your conditions that they're not really going to cost a whole lot of money to treat because people aren't going to go into the hospital. You know, plain hypertension, GERD, things like that, but you are going to write prescriptions for them. So as David said, there are some that correspond. So there's an HCC component and there's also an RxHC component. There are some that also stand alone that are you just get the RxHCC for. So you want to make sure that you're getting all of that information in front of the provider so they know to make sure they're getting those documented to build up that Part D risk score as well, if that helps from a clinic, you know, thinking clinically about that.
All right, great. Ryan, hopefully that answered your question. If not, feel free to ask a follow-up in the Q&A. I'll go to our next question, which is from Michael. Does CMS have a mapping of which sub-procedure CPT, HCP, CS codes are acceptable to support each submitted HCC?
Yeah, that's publicly available. If you Google CMS risk adjustment, you can find it in one of those links. You might have to do about 10 or 15 minutes of internet hunt and peck to find it, but it is publicly available and pretty easy. If needed, we can provide that. I can just look it up myself and provide that file after the webinar.
Perfect. All right, let's go to our next question, which is actually from Noe put that in the chat, so I moved it over to the Q&A. And David, you might have answered this in the chat, but maybe we can just do it verbally. Are POs currently submitting V24 and V28? Has V22 been officially obsolete?
Yeah, I answered in the chat. So V22 is not obsolete. It's still 90% of the risk score in 2026, but it's actually submitting RAPS versus EDS. And the little quirk is EDS actually counts under both the V22 score and the V28 score. So in a hypothetical ideal world, if your diagnosis set from the EDS submissions wholly cover your RAPS submissions, you don't even need to submit RAPS because EDS counts for both. Now, I wouldn't necessarily recommend you do that right now because of the gaps you're seeing, but you know, it's even more reason to get your EDS process in line because it's still 90% in 2026, and that's a pretty big deal. Then, as I said, V24, that model is being completely skipped. This process took so long to go from the MA to the PACE world that there were actually 2 iterations of EDS models that are no longer used.
All right, perfect. Michael had a follow-up, which I think we can probably just send it out afterwards, David, but the follow-up was only the list of CPT, HCP, CS are available. I couldn't find a mapping. Can we relay the mapping to him as the follow-up from the webinar?
Yeah, that's out there somewhere.
Okay, we will find it and include it in the notes that we send out for the webinar. And that's a good time for me to mention, we are recording the session. We'll provide the recording as well as the slides post-webinar. It's possible we could have it by tomorrow, latest early next week. Sometimes it takes a little bit to compile everything. And the last question that I see in the chat right now is from Cameron. Cameron says, our organization received a preliminary payment number significantly lower than expected, around 30%. Is there a place within CMS that we can go in order to verify the data that we submitted? Anybody want to take that one?
Yeah, the MAO4 and RAPS return files will verify the accepted diagnoses. And from an EDS perspective, the interim MAO2 and 277 files will verify the set of 837 claims that were deemed acceptable from a claim form standpoint that were then allowed to be filtered for risk adjustment. So the simple answer is look at your MAO4 and RAPS return files. And then the more complicated would be the MAO2s and 277s to verify that ADS submission process is functioning.
Yeah, and just to follow up on that, ultimately, whoever is your partner that is submitting that data should have a collection of that data and what status all of that data for a particular period of time is in. And ultimately, the process should be taking all those files that David mentioned and reconciling and giving you a little bit better user-friendly look into what was submitted and what was accepted and what was denied and why was it denied and so on. So your partner should be helpful. And if that's us, let us know.
And that's also where we come in. We can project exactly what your risk score is your revenue is going to be for 2026 based on those set of files and track it. And sometimes people get surprises, and that's why it is important to track and see where you're at, so you don't get a bad surprise at the end of the year after there's nothing you can do about it.
All right, wonderful. That was the last question that I see in the Q&A, so I will go ahead and wrap us up here. Again, thank you to all of our experts for joining us today and walking us through cracking the case. Hopefully you leave this session a little bit with a little bit of understanding about what's coming and some ideas about how you might go about closing the gap with any and all of the vendors that were showcased here today. If you do have additional questions or would like to follow up, you can always reach out to me. I put my email address in the chat there, or you can find us on the IntusCare website. And I'm sure all of our experts would also be willing to talk more should you have additional questions or follow up. So be on the lookout for the recording and slides from this session. And I wish everybody a happy Thursday and a happy holiday season. Take care. Bye-bye.